This presentation is adapted from Sleep Academy, an online CME-accredited course for advanced practitioners and physicians. My name is Dr. Peter Sloan, and I'd like to introduce Dr. Brian Bonner.
So the first study I'm going to talk about is the polysomnogram, the PSG. And this is the traditional study over the past 20 to 25 years that most people have referred to when they say, I had a sleep study. The study is performed in a monitored facility. There is a technician who is monitoring the patient while the recording is taking place. Often this is referred to as the in-lab sleep study. It can be done in a hospital or an outpatient facility. It's always conducted by a registered technologist. And in most states, licensure is required for that technologist. Most common indications, it is to establish the diagnosis of sleep apnea and assess or modify positive airway pressure therapy. So let's take a quick look at the physiology that's measured. The EEG is performed to basically be able to stage sleep. So we want to see the front of the brain, the middle, and the back, where different areas are more specific for the waveform features of certain stages. You'll notice to the right here in this diagram, this is known as the 10-20 system, and this shows where the electrode should be placed. And you'll notice that there's 9 dots on the top of the head. Typically, there will be the 6 outer ones that will be used for the electrode placement. And then there will be a reference electrode over the ear, which is labeled A. The skin is very gently rubbed in the areas where the electrodes are to be placed. Important for the patient to know that no electrical activity is delivered to these electrodes. They're simply measuring activity in the brain itself. And so there will not be anything uncomfortable about the application of these devices. The next parameter is the electrooculogram, or EOG. And the electrodes are similar to the EEG. You'll notice that they are placed one above the eye and the other below the contralateral eye. And the reason for this is so that when there is eye movement activity, we would expect it to move in opposite directions, as opposed to artifact from other things that could be moving in the same direction. This definitely would differentiate what is eye movement versus something else. The EMG is measuring the muscle activity in the chin, because during the stage of REM, there will be elimination of any activity in that muscle. Also, there will be a lead on each calf to measure limb movements. When we measure breathing during sleep, it's very important that we measure airflow. This is most commonly conducted with a nasal cannula, and this is a transducer that will measure airflow with a manometer. And it's certainly more comfortable than the standard measurement of airflow. The gold standard would be a pneumatachograph, which is, if you can envision someone in a PFT lab with a clamp on their nose and a mouthpiece through which they're breathing, that would be the absolute perfect way to measure airflow, but certainly not something that's very comfortable for a patient when having the study done. You'll see that the measurement of respiratory effort is very important during a study. The gold standard here would actually be a device that's actually placed into the esophagus, an esophageal balloon, to measure changes in intrathoracic pressure. Again, not a very comfortable device to wear in a clinical situation, and certainly one way to scare patients off from going into your sleep center if you use that on a routine basis. But so typically the way to measure effort is through a RIP belt, or a respiratory impedance plethysmography. You'll see in the RIP belt that the white undulating lines going through the belt are very sensitive to measuring changes in excursion of the chest wall to allow us to see respiratory effort. A microphone to measure snoring, typically taped over the side or the front of the neck. So don't turn the lights out just yet. You also need a single lead EKG. You need a pulse oximeter, generally a finger. You'll need a body position monitor, and some of the RIP belts actually will measure body position. And finally, an infrared video monitor. For patients who are going to have a positive airway pressure titration or who might have one halfway through the study, there's also going to be two leads on the study, one to measure mask pressure and the other to measure leakage from the mask. So what does a sleep study room and what does the equipment look like? Well, in my first sleep lab in 1990, this is what the monitoring equipment looked like. You'll see on the left is an EEG GRASS machine that's measuring high frequency and low frequency activities, each having their own spot in the setup there. And then the study is recorded with the paper, you can see in the bottom left, printing out as it's being run, so that by the morning there is a stack of paper that is about the size of 2 or 3 phone books. So moving on to a more modern rendition of a sleep study, you'll see on the right is what is known as the head box, and this basically, along with a laptop or a desktop, will completely replace the entire GRASS machine and the 3 phone books of paper that we used to use in recording a sleep study. The patient here, having been hooked up with all the parameters we talked about before, can simply unplug the wires from the top of this head box, go to the bathroom or take a break, and that question often comes up with patients: how do you deal with all those wires?
If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.